Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and we are going to take up this investigation of lung diseases. Now, this is part 1. In part 1, I'm going to cover this spirometry, and in second part, I will cover some more pulmonary functions like diffusing lung capacity and phenox. But here I'm going to mostly focus on spirometry. Now, before we talk about these tests, let me say one thing, that most lung diseases are clinically diagnosable. But of course, spirometry gives you some more insight into the exact nature of the disease and also to exactly quantitate the disorder. This is just an incomplete list of commonly performed lung functions. We have imaging tests like X-rays, CT, ultrasonography, and many other imaging tests. We have pulmonary function tests, primarily spirometry, which we are going to talk about today. Then arterial blood gas and pulse oximetry are covered in separate videos. Bronchoscopy is beyond my scope because I don't normally do them. And pleural fluid examination and sputum examination and biopsy can also be discussed in some other lecture. So we are going to talk about one component of pulmonary function test, that is spirometry today. Now, just going back to your physiology, I think we have to do this, otherwise we will not understand certain terms. These are lung volumes and capacities. Now, this is a curve taken from a normal healthy person. The patient breathes in and breathes out like this in a normal basal rate. So this is inspiration, expiration, inspiration, expiration like this. And this is recorded on spirometry. At this point, and this is a resting tidal volume. This graph, this wave is equivalent to this blue column. So this is resting tidal volume. At this point, patient is instructed to take a deep inspiration, as deep as that person can. And this would add then inspiratory reserve volume. And then after this complete inspiration, patient is instructed to exhale as fully as possible. So this would add then expiratory reserve volume also. So the total of inspiratory reserve volume, tidal volume, and expiratory reserve volume is called vital capacity. So in vital capacity, we allow the patient to take as much time as patient wants. Usually time is not restriction, so patient continue to exhale. Then patient is usually able to exhale maximum amount of air. Sometimes we use the word forced vital capacity. It is the same thing, but we ask the patient to exhale as hard as possible and as fast as possible. So then I think since we have limited the time and patient uses force, that measure is called forced vital capacity. That is actually, you may be surprised, usually less than the vital capacity for two reasons. Number one, although you have not restricted time in number of seconds or anything, you have asked the patient to do it as fast as possible. The other thing is, when patient does it with force, because of raised intrathoracic pressure, some of the small airways are compressed, and that actually reduces the total amount of air exhaled. And then again patient resume the normal quiet breathing, and this is tidal volume. So with this background, and there is a certain amount of air, for example, below this residual volume, no matter how much effort patient applies, patient cannot exhale this much. This is the residual volume. This must stay in the lungs, and the total amount of air, including vital capacity and residual volume, is called total lung capacity. So with this background, we are going to take up this spirometry. There are two types of devices. One is simple peak expiratory flowmetry, and the other is proper spirometry. This is just simple handheld device. It used to be a simple mechanical thing, but nowadays they have the digital devices. This is the proper spirometric equipment, and this used to be very bulky, but with digitalization this has also become very small and handy. So with this device you can measure just one parameter of ventilation, that is peak expiratory flow rate. And with this one you can measure multiple parameters as you program. You can measure FEV1, you can measure vital capacity, you can measure FEV1 divided by forced vital capacity percentage, and whatever you program it, it will measure. So this is the proper equipment, and this is just handheld. Patient can actually keep this one at home, and like one keeps blood pressure apparatus, one keeps blood glucose monitor at home, a diabetic patient. Similarly, patient with lung disease may be instructed to keep a peak flow meter at home and measure his or her peak expiratory flow rate. Now, one thing I think I'd like to you to note that both these peak expiratory flowmetry or spirometry, both of them, they simply measure mechanical functions of lung. They measure how much air goes in, how much air comes, what is the obstruction, what is the restriction. They do not in true sense measure pulmonary function. That is measured with other tests, which I'm going to cover in other videos. Now, the strengths and weaknesses of pulmonary function test, spirometry function test in general. The strength is that it will tell you if the lung disease is obstructive airway disease or restrictive lung disease. Now, many lung diseases, especially those which cause dyspnea, they can be classified into two broad categories. Either obstructive airway disease, that primarily means that there is a narrowing of small airways or sometimes large airways, or the restrictive lung disease, there is problem with the expansion or the volume of the lung. So number one strength of the spirometry is that it will surely tell you if the disorder is primarily obstructive or restrictive, and if it is combination, how much obstruction, how much restriction. And number two, it can give you the exact quantitative value. For example, you would know how many liters, so then you can measure it again and again. That of course is not possible clinically. Clinically you can't exactly quantitate it, but this spirometry can give you the exact quantity. So these are two strengths of this test. But the weaknesses are, number one, it does not give you a specific diagnosis. You have to interpret these tests in the proper clinical context to have some meanings. So this is like limitation, and it is effort dependent and technique dependent. So how much effort patient applies and how well the patient understands what to do and how experienced is the technician. So all these can significantly affect the results. So if there is any situation where spirometer functions, they do not match with your clinical judgment, of course you have to review your clinical judgment also, but you can also have the test repeated. Maybe there is some fallacy in the test. Now this is the same, but this time I am talking about certain terms that we use in medicine, in clinical setting. Forced vital capacity, I have already explained. Forced expiratory volume during first second. Now this is another parameter. In obstructive airway disease, it is the first second. It is the amount of air in absolute quantity, not the percentage. It's sometimes made in percentage also. It is the amount of air in liters or in percentage which is exhaled during the first second of expiration. In obstructive airway disease, this is the parameter which is particularly affected. And if we take this one, FEV1 divided by forced vital capacity, and we take the percentage, this is the most sensitive criteria of obstruction. So we use, I think, this one mostly. Then of course, peak expiratory flow rate, and this will be measured with peak expiratory flow meter, and you just measure the maximum velocity achieved during forceful expiration. Of course, patient is not allowed to cough. He has to exhale forcefully, and the maximum speed, not the volume, the maximum speed achieved during expiration, that is recorded, and that actually corresponds with the airway obstruction. So these are some of the pulmonary function tests, and I'll show you the normal spirometry graph and the spirometry graph in patient with obstructive airway disease. This is the normal forced vital capacity and forced vital capacity during first second. Now this is the expiration, and this the volume goes like this, and this is the time, first, second, third. So in, I think, 6 seconds patient has completed his expiration. But notice that maximum air, like 4/5 of the total forced volume, was actually exhaled in the first second, and this is possible only if your airways are patent. Now if you compare a spirometric curve with the patient who has obstructive airway disease like asthma, look at this one. Number one, the total volume exhaled, forced vital capacity, is much less than normal person, and the amount of air exhaled during the first second is particularly reduced. So here it is 4/5, it is only half. So that is why I say FEV1 is very sensitive indicator. So normally this is the traditional curves, but nowadays they give result in the form of a volume loops. I'm going to show you that also. This is the normal flow volume curve or loop. Now this is inspiration. Below, the blue color is inspiration, this one, and here the expiration starts, and this is the expiration, and this point corresponds with the peak expiratory flow rate and then goes back. So this repeats itself like this one. This is normal flow volume curve. Now, as I said earlier, that this is effort dependent, technique dependent, and there are many variables which can give you wrong readings. So this is poor effort. Patient did not have any lung disease, but patient did not apply proper effort. This is short blow. Patient did not exhale. Normally, I said patient is asked to take as much time as needed, but this patient prematurely terminated his inspiration and then went on to expiration. This is a cough during recording expiration. This is premature finish and restart, and this is patient is just hesitant. And you know, sometimes we see all types of patient. Patient is usually nervous, and patient may not be very comfortable doing the test, and sometimes patient may be doing it intentionally. In forensic medicine, we have learned that sometimes patient will do it intentionally for one or the other reason. So beware of these faulty results. Now this is the example. I repeated pulmonary function test in asthma. This is normal, but in asthma patient, see, the inspiration is hardly different than the normal one. It is the same. It's a similar curve, similar volume. Because patient takes longer time, patient has to apply more force, but patient manages to take in the amount of air that person normally does. Mainly it is the exhalation, the expiration where patient faces difficulty. Curve should be like this, but it goes like this. So this affects, this is the first part, this is the second part. This would of course affect FEV1, and this would affect the forced vital capacity. Now theoretically, if patient is given bronchodilator, if patient has obstructive airway disease, then after treatment patient will have restoration of normal curve. So this is the pulmonary function test in asthma, which is the prototype of obstructive airway disease. This is not the spirometry. As I told you, this is peak flowmetry, and this is very simple device. This pointer is here. Normally a patient is asked to take a deep inspiration, as much air patient can take in. Then you can apply a nose clip sometime, or patient can hold his nose with the left hand, and the right hand he holds this, and then after taking a full inspiration from the nose, patient exhales fully, not coughing, but he exhales fully, and this pointer will stop at the maximum speed. So you will record 1 million. The strength of this equipment is it is extremely simple, no gadgetry, no battery, no electronics. So I think patient can do it as frequently as the patient wants. Now, classification of lung diseases. Now, based on the pathophysiology and also based on pulmonary function tests, lung diseases can be classified into 3 or 4 groups. One is obstructive lung disease. The other is restrictive lung disease. And then we have combination. There are many lung diseases where there is element of obstruction as well as restriction. And then of course there may be a lung disease, there may be an advanced lung disease, but there is neither obstruction nor restriction. So pulmonary function tests, they are useful in this situation. Types of lung diseases. Now I'm going to give you the examples. Obstructive airway disease is a disease there is obstruction to the airflow. Of course, there could be obstruction to the main airways, extrathoracic or intrathoracic. But we normally, when we say obstructive airway disease, we usually refer to the small airways, bronchi. So if the problem is the bronchi, prototype is bronchial asthma, or it may be chronic bronchitis or emphysema. Bronchiectasis or some other lung diseases can also cause some obstruction, but I think I will consider bronchial asthma, chronic bronchitis and emphysema as classical airway obstructive diseases. Now, examples of restrictive lung diseases, total lung volumes is reduced. So there is problem with the total lung volume or expansion. So examples are interstitial lung diseases. There is a whole long list of interstitial lung diseases. Pulmonary fibrosis is one of them. Pleural effusion. Now, pleural effusion is not strictly speaking a lung disease, but it will produce the same result, same pattern as we have in other restrictive lung diseases. Ankylosing spondylitis is again a disease which affects chest cage, but it is going to affect the expansion. So I think there are many other conditions, like even obesity can be classified as a restrictive lung disease. So you cannot make any sense out of these tests unless you correlate them with the clinical condition for the patient. Now, what is normal? Whenever we talk about any test, any variable, we usually compare it with the normal. Now, what is normal? You know, if you are a child or if you're an adolescent, if you're a male, or if you're a female, if you're well built, if you're small, if you're tall, if you're short, the value is likely to be different. So that is why this concept, the normal value is calculated for that particular individual. And this is also referred to as predicted value. What was the value which was predicted in that person if that person was healthy, based on age, height, gender and race. So whenever you go for a pulmonary function test, you will be asked these parameters and they will be fed into that computer, and that computer will calculate this much FEV1 or forced vital capacity is predicted. So that will be considered normal for that person. So obstructive air diseases. Now I'm going to, just to make it more simple, I think I have given you the main message already, but I'm going to give you examples and all the parameters which we measure in pulmonary function tests and spirometry. I'm going to take them one by one to make the message more clear. Now first we'll take obstructive airway diseases. Imagine bronchial asthma. What happens to vital capacity? Here you are going to be surprised. I say maybe normal, maybe less or maybe normal. Why? Because there is no time restriction. Patient will have to exert more. Patient will take much longer. The expiration will be prolonged. But if given time, patient may be able to exhale the amount of air he or she was expected to if there was no lung disease. It may be reduced a bit, but it may not be significantly reduced. FVC, forced vital capacity, that is usually reduced because you have asked the patient to do as quickly as possible. So because of the time restriction, forced vital capacity will be reduced. So we use forced vital capacity in clinical situation. Forced vital capacity during forced expiratory volume. So this is forced expiratory volume during first second. Now this will be particularly reduced because I just showed you the graph. It is the first part of the expiration which is mainly affected. So there will be marked reduction in FEV1 in terms of the volume. The total amount of air exhaled during first second will be reduced. But the parameter which is affected the most, and because of it is affected the most, it is then the most sensitive. It is forced expiratory volume during first second divided by forced vital capacity, and we take the percentage. What percentage of the forced vital capacity is exhaled during first second? Now this is particularly effective. So I think if you want to use one parameter to diagnose obstructive airway disease or to rule out obstructive airway disease, it would be FEV1 FVC percentage. Okay, so all these four parameters are maybe affected, but it is FEV1 divided by FVC percentage which becomes the most sensitive parameter. Similarly, if you use peak flowmetry, the equivalent of spirometry, peak expiratory flow rate will be, of course, reduced. Now, not only just one measurement, you can monitor these patients and see how things are improving or otherwise. So this is the advantage of pulmonary function test. Now we are going to discuss the same parameters in restrictive lung disease. And you remember the example, interstitial lung disease and many other conditions. So just take the prototype as interstitial lung disease. Vital capacity is reduced. In fact, vital capacity is more significantly reduced in restrictive diseases as compared to obstructive diseases. Why? Because lungs can't expand. The alveolar volume is reduced. So patient can't take air in because there is no space or reduced space. So that is why vital capacity is reduced. Forced vital capacity is also reduced. It is only another form of vital capacity that is also reduced. What is FEV1? Forced expiratory volume during first second. This is going to surprise you. It may be normal. Why? Although the total amount of air patient can exhale in the total expiration is definitely reduced, as I just said, vital capacity, forced vital capacity are significantly reduced, but the amount of air exhaled during first second may not be affected to that extent. Patient still can manage to exhale the normal amount of air during the first second. So if you take forced expiratory volume and vital capacity percentage, this is also going to be normal. Because, although FEV1 may be reduced to some extent or not reduced, but since forced vital capacity is reduced, so this value is not only likely to be normal, in some cases it may be actually increased. So percentage of forced vital capacity exhaled during first second may be normal or increased in restrictive lung disease. Of course, forced vital capacity and vital capacity are reduced. And what about peak expiratory flow rate? Peak expiratory flow rate may also be normal or minimally effective. Why? Because patient may not be able to sustain expiration for long because there is a small amount of volume that person has to exhale, but patient can achieve the speed the normal for him or her because the airways are patent. Although many types, actually obstructive airway disease and restrictive lung diseases are together, whatever examples I'm giving you, this portrays the typical prototypes, but of course in real life we have combinations. So you be aware of those combinations. Now this is the summary of what we just discussed. Parameters, obstructive lung diseases and restrictive lung diseases. We just covered all these individually, but just for the comparison, these are the three curves. This red one is normal lungs. You can see this is the normal. This much is forced vital capacity, and this point indicate the FEV1. In obstructive airway disease, this is blunted and flattened curve. So you have a reduction in forced vital capacity, but you have much more reduction in FEV1. And if we compare FEV1, FVC percentage, it will be particularly effective. Here, there is a reduction in FVC, maybe not as much as in obstructive airway disease, but see, FEV1 is relatively intact. So percentage of FEV1 by FVC may be normal, or as I just told you, maybe increase. So this is the graphs, and just let's go through. Forced vital capacity is significantly reduced in obstructive airway disease and less so in restrictive lung diseases. Forced expiratory volume during first second is more significantly reduced in obstructive airway diseases and may be reduced in restrictive lung diseases also, but less so. FEV1 divided by FVC per year in percentage is much more affected in obstructive airway diseases and maybe normal or maybe increase in restrictive lung diseases. And DLCO will be actually discussed in my next video, because this I'm going to take another video to explain this. So I hope with this comparison you have understood how pulmonary function tests can help to differentiate obstructive airway disease from restrictive lung disease, and also to quantitate. For example, if this curve was here, that would mean lesser problem. If this curve was here, then you would mean the more problem, more obstruction. Now, based on these parameters, you can quantitate the disease, and of course I will not need to go through these numbers. Just as the percentage of FEV1 reduces and the severity of lung disease also increases. If you use one parameter, I told you it is a percentage of FEV1. Okay, so that is the most sensitive parameter. Based on that, you can have normal person or very, very severe abnormality. This person, of course, in fact, this and this would be symptomatic even at rest with very severe limitation in physical activity. Now that brings me to the end of this presentation, and now I'm going to present the summary. And summary is that the spirometry is useful to differentiate between obstructive and restrictive lung diseases, to quantitate the abnormality, you know how much obstruction or how much restriction, and to determine the reversibility. What is the reversibility? That means in asthma, first we do pulmonary function test, and then we give bronchodilator, and after 10-15 minutes, usually in the form of nebulization, and we repeat the test after 15 minutes, and then we see if there is any improvement. So if there is significant improvement, that would mean reversibility. That would mean that patient would benefit from bronchodilator therapy. To follow the prognosis, of course, whatever treatment we are giving, we want to know if patient is improving. Of course, patient symptom will also guide us, but to be more objective and to be more precise, we will have to measure the pulmonary function test, and we can see how much is the improvement. Now, if there is no improvement, we can maybe try harder with other agents, and patient is improving and if facing side effects, then maybe we can step down. So that is how this is really. And if you're studying some experimental medicine, then also these pulmonary function tests are very useful. So that was all. This is Professor Aziz-ur-Rehman from Medurstand-Understanding Medicine. I really want to see you in my next video, which is going to cover DLCO and PHENOX, other two pulmonary function tests, and that will be followed by arterial blood gases and spirometry. I strongly urge that you follow all these videos to have good concept about pulmonary function test in total. Thank you.